Thank you. So topic now, prevention of infection and total knee arthroplasty. And I don't think I need to tell this audience the tremendous burden that the infected total knee, and total hip for that matter, is on a global issue. The incidence is a little under 1%, up to 2.5% depending on the series. Devastating complication for the patient, certainly for the surgeon, and an enormous healthcare cost. So I'm going to take you through for the next few minutes my approach to trying to minimize infection and total knee arthroplasty. And that would be issues related to patient factors, which you can't always control, intraoperative factors, some of which you can control, and some postoperative factors. This is how I think of it as a clinician. So first, let's say patient factors. Gender. Small series show no difference in infection rate. I will refer you to this paper. This is an excellent paper published a year ago in JBJS looking at 43,000 total knees in the Finnish Arthroplasty Register, and it's got a lot of very good information. It actually showed a slight difference between males and females, 1%, 0.7%. And while that's interesting, I think gender-altering surgery is hard to recommend prior to a total knee arthroplasty, so it remains a fact, but yet something I can't really control much of. What about the diagnosis? So osteoarthritis, our bread and butter, the incidence about 0.7% in that series. Rheumatoid arthritis was double that. So let's take you through some of these things. What are the current recommendations in rheumatoid arthritis? Well, most of them are on NSAIDs. It's a weak antiplatelet effect, so our routine is to stop that for about 10 days prior to the OR. Steroids, a lot of them are on steroids. It's a tapered dose, IV to avoid adrenal crisis. That being said, recent literature suggests 3 doses at 25 milligrams should cover that patient and then get them into the postoperative period. Methotrexate remains controversial. I've always stopped it for my patients. 2 recent publications show there's no increased complications maintaining it with regards to infection. That being said, I don't know, maybe I'm just wrong or old school. My feeling is it'd rather be off it than on it. Now, there's a whole host now of new medications. Leflunomide must be stopped because it does increase the infection rate. TNF blockers do not. So you start saying, well, how am I going to keep track of all this? Well, I keep track of it. I ask my rheumatologist, quite frankly, what medications can this patient tolerate to be off for at least 2 to 4 weeks around the surgery to try and increase your immune response and decrease the risk of infection. Diabetes, poor control, and higher glycosylated hemoglobin concentrations increase the risk of infection. That being said, how many here, in terms of their pre-admission clinic, screen for this? I mean, we still don't screen for it at our place. There's 2 excellent papers that suggest we should, and in point of fact, we're now going to start screening for it. But by about the summertime, they're going to have it part of the protocol. Because if you control the patient's diabetes better, the risk of infection is clearly less. What about obesity? Well, we know as clinicians that risk of prolonged drainage is well documented. Does it increase the risk of deep infection? Probably, but that's not as well documented. While we suggest to patients weight loss counseling and gastroplasty surgery, we do not even have a gastroplasty surgeon in our city, and our approach really gets the patient to the OR at the same weight. Very few of them, quite frankly, lose weight. That's a bit of an issue because the obesity rates are skyrocketing, and the United States gets to win. Yay, they win on this one with the highest obesity rates, but many countries are following suit. And what's shocking is that over the last 20 years, obesity prevalence has doubled in adults and tripled in children to the point where now a full third of American adults are obese, and it accounts for up to 10% of the total healthcare costs. The heaviest BMI groups are increasing at the fastest rates, and 5% of the U.S. population has a BMI of over 40. When I started in practice, my own BMI was a bit less too, actually, but my patient's BMI average was 29, and now it's just under 34. That's in 14 years of practice. But I can't control a lot of these things. What can I control in the intraoperative factors? Antibiotic prophylaxis, I think that's the standard of care. I think we all appreciate that. The bugs are becoming a little bit different, but our go-to is still NSAID unless they're allergic. What about the OR suite? Not all of us have laminar airflow for each and every room, but you should have a high airflow turnover. That's important. UV light's effective, but I don't know of a single center that uses it routinely. But one thing I will say is OR traffic. There used to be a mystique to doing a total knee, and I remember Cease Robeck and Bob Bourne in our place, you barely could get in the room. And we've tried to maintain that because the more OR traffic you have in your room, the more surface contamination you get and the higher your infection rate. So minimize OR traffic if you can. Sterile techniques, breaks in sterile techniques are fairly common, so change your new gloves prior to handling implants. I think that's a good technique to maintain. It's easy. You're in control of how long the case takes you, and evidence upon evidence suggests that the longer you're in the OR with that knee open, the increased risk of infection. So try to be efficient in your use, and that's been confirmed in papers and registry data. In terms of antibiotic cement, a quick show of hands. How many here routinely use antibiotic cement in every total knee? So for those at the front, that's probably about 30 to 40%. While there's tremendous global variability in its use and practice, I will say one of the drivers is you'd need about 8,000 patients in a prospective randomized trial to show its efficacy. We have to rely on registry data that is valid in large series with large numbers. And I'm going to skip quickly through this because we have paper after paper, registry data that very well confirms decreased infection rates if you use antibiotic cement. There's a 1% in the Norwegian registry. This is another paper that shows the best performing cement was that had gentamicin in it. Even within the same class, Palicos and CMW, the best performing cement always had antibiotics mixed with it. That's for septic and aseptic loosening rate. Here's a series of 160,000 total hips that showed the exact same thing. Best performing cement had gentamicin in it. The Norwegian registry, the lowest risk of failure for sepsis and asepsis if you used IV antibiotics and antibiotics in your cement. As soon as you use it only intravenously, you have a 1.3 times increased risk of aseptic and almost a double risk of septic loosening. It should be, I think, part of your practice. Lastly, the Finnish registry, 43,000 total knees. There's the intravenous infection. If you only use it, IV antibiotics intravenously, 1%. If you combine it, you're all the way down to 0.68%. The risk or the worry has been resistant organisms. Hundreds of thousands of these now have been done, and there's no evidence at this moment that resistant organisms are an issue. So I think we need to be a little bit leery of that. Current practice, we've used antibiotic cement in every total knee patient since 1999, and I have not had a single infection. Okay, well, I've had a few, but still, I think it's a good idea to use as part of your practice. And lastly, postoperative factors. I think drain use continues to be no convincing evidence either way. DVT prophylaxis we all employ, but important not to use it preoperatively. And lastly, wound complications. You know what? The thing that bothers me one of the most is when things are not dealt with appropriately. And wound infections and hematomas and necrosis, if they're not dealt with properly, all increase your risk of deep infection. These things don't get better on their own. They need to be addressed. Be aggressive in dealing with these issues. And antibiotics for dental work, I think we've beaten that up. So approach to prevention of infection in total knee needs to consider the patient, intraoperative, and postoperative factors. Put them all together. A multifaceted approach is always best. Thank you.